I'll do my best to keep up with the 154-page packet.
I almost accidentally printed it. Print out the agenda, and then I realized it was 150 pages. I was like, wait, whoops, what is all this?
It's a hefty one.
Yeah, not for printing. Okay, I guess since it's 10:30, I won't waste any more of you guys' time. We can get started. So we'll go ahead and call the meeting to order, and we'll begin with a roll call from Shelley.
All right. Good morning, everybody. I've got Amber Rice.
Yes.
Brian Smith.
Present.
Chester Key. Looks like Ed Mazulis is next. Ed? Josh Gaither?
Here.
Christina Long?
Here.
Matt Shaw?
Here.
Orlando Alcordo?
Yeah.
Paul Honeywell? Ryan Harold?
Present.
Sandy Nygaard? I saw Sandy. Sharon Hollingsworth?
Good morning.
All right. And Stevie Merrill? Sorry, here. All right, we have quorum.
Great. So moving on, the chairman's report. And so we just have the attendance report that's attached below or in the third page of your packet. You guys can take a look at that. Just a reminder, if you miss 2 consecutive meetings, the Bureau is going to email you and ask if you still want to be involved on the committee. And at this time, we have no new members to report and no vacancies on the committee to announce. And then moving on, that's all I have in the chairman's report. For the Bureau report, I have Julia.
Good morning. Do you want to mute the sound on your computer? Okay, sorry. Good morning. Not a ton to report for EMS for children. However, we did conduct our annual data collection among EMS agencies this past January through March, and we did receive the results of that. So just probably most of interest to this committee is the performance measure use of pediatric specific equipment. We had 101 total agencies participate in the survey, and then 28 met that performance measure. So 27.7% met the performance measure for the use of pediatric specific equipment, compared to the national percentage of 25.5%. So we're right around average on that. If you are interested in the full report, you can reach out to me and I would be happy to share that information with you. End of report.
Julia, this is Terry. Can I ask a question about the report?
Yes.
Do you happen to know what our previous score was?
Yes, that's a great question. So for that performance measure, our last score was right around 20%. So we did increase. The number of agencies participating also increased, however, so it might not be a complete accurate representation of the increase, but we did show an increase in that.
Thank you.
Okay, thanks, Julia.
Any other questions?
Okay, moving on to our discussion and action items. The first one I have is to discuss, amend and approve the education meeting minutes. So if I have a motion to discuss the education meeting minutes from the last meeting.
So moved, Brian.
It's Josh. I'll second.
Okay, thank you. So in the packet, you have the meeting minutes from the March meeting. If you guys want to look through and let me know if you guys have any amendments that need to be made for that. And if not, then we can take a motion to approve the minutes.
Are we waiting for a motion to approve?
Yes.
It's Josh. I can move to approve the meeting minutes as is.
Thank you.
This is Sharon Hollingsworth. I'll second that.
Okay. So we'll call for vote. All those in favor, say aye.
Aye.
Aye. Aye.
Cool. And any opposed? Great. For our next action item, we have to review the posted training modules. So if we have, there's a list in your packet as well of all the training modules, and then we can move on to discussing and amending and approving the updates to some of these PowerPoints that we got some volunteers to help out with on the last meeting. So if I can get a motion to discuss the sepsis, identification and management of sepsis PowerPoint.
So
This
moved,
is Matt.
Brian.
So moved.
Great, thank you guys. So in this PowerPoint, I got a little bit of feedback from Sandy Nygaard, and I've included those in these edits as well. So if we kind of scroll through, I tried to just make the recommended changes obvious. So slides that either myself or someone else recommended deleting will just have a big black X on them so we can discuss moving these out. This slide, I think I just felt like for EMS providers, I wasn't sure how helpful this was in identifying or understanding what sepsis really was. Really trying to compare it to anaphylaxis. So my recommendation was to remove this slide.
Agreed.
Moving on, if anyone doesn't have any more comments about that. This one also, so sepsis versus stroke and stemming. This, I think, was just a visual representation to talk about it as like a time-sensitive illness. I wasn't sure how helpful this was. I think going down, there was another similar slide. I think was what, yeah, if you go up to that green one, it talks about like mortality compared to other things. I just wasn't sure if we needed both of those slides in there. I don't know. You want to scroll back up to the one with the X on it. I think it's just kind of talking about the time-sensitive nature, the high mortality.
Amber, it's Josh. My opinion on these things, particularly when you have a PowerPoint that's designed to be used by different end users, slides like this that have no content on them and that leave it open to interpretation also lead to the possibility for misinterpretation. So I would support removing this slide.
Okay. I mean, there was some stuff in the notes about it, like in the notes part, but I still don't know that it was helpful in teaching about stroke. Or I mean, sepsis versus stroke and STEMI. And then the slide below it actually has a little bit of a graph that does show you the mortality of it. So I think you can sort of at least make a comparison here using the slide about the significance of having a patient with severe sepsis compared to some of these other things. So that slide I do think might be helpful. Moving on to the next one, I sort of recreated this slide a little bit just because I found it difficult to read, and there were things in it like very specific lactate levels and things like that that I made less specific and just talked about it being an elevated lactate versus like specific numbers that wouldn't have any relevance to an EMS provider. So I just tried to make it a little bit more, I don't know, a little more EMS friendly and took out some of the stuff that was more hospital based and tried to keep it more simple. I combined it with this other slide here, the slide above it, kind of showing the increasing mortality, and really just put the label at the bottom of the septic shock one that said 50% mortality. The others I thought were a little less relevant. So if anyone has any other suggestions to change this or anything, I'm totally open for suggestions. If not, we can move on to the next one. This is really just repeating kind of the slide above, so I sort of recommended deleting this one since I don't know that the numbers would be relevant to people. And then this was the same thing, this sepsis spectrum. So I felt like it was just a lot of sort of redundant information. If anyone feels like we should keep any of this in, just sort of let us know. I did leave that one in just because I didn't want to take every single one of them out. I don't know how helpful it is, but kind of shows the increasing severity. This slide, there were no recommended changes. Or on that one, which is just the pathophysiology. We're talking about SIRS, risk factors. This, I just changed the spelling of the word quadriplegic. It was misspelled. That's all I changed on there. This one, or the one above, Shelley, I didn't, the one where it says reduced immunity. This one was, I don't know, I had difficulty with this one and the one before it because I don't know that recent antibiotic use or indwelling catheters necessarily give you reduced immunity. The other ones.
Amber, this is Gail. Maybe just saying increased risk for sepsis.
Yeah. Yeah, and the slide above it, I think, also says reduced immunity.
So maybe just retitling both of those.
Yeah, just say like increased risk for. So what slide do those? That's reduced immunity. Increased risk for sepsis. Okay, I can change those as well. Okay, moving on. This one, I wasn't sure about signs and symptoms of sepsis. There were a lot of things in here. Some of them really overlap. I don't know if we want to keep all of them. I had recommended striking through the arthralgias one. I don't know that that's a very common sign or symptom of sepsis. Although I guess you could have that. I just don't think of it as generally being in that category. Just trying to reduce the sort of number of words on the slide a little bit. This one, I can't remember what the original title of the slide was, but it didn't really describe, I don't think, what this slide was, and so I just changed the title to multiple organ system dysfunction. just to talk about the fact that the slide sort of hits on, you know, the multiple organ systems affected and what the sort of what that patient might look like or have as a result of organ system dysfunction. So I just changed the title. Going down, we have causes of sepsis, the bundles. This graph really just kind of shows the it being sort of a medical emergency, the time-sensitive nature of recognition. So it talks about the time to antibiotics and the survival rate. Just to highlight that, you know, sooner recognition from EMS might, you know, improve their time to antibiotic. Following this is some literature about EMS and sepsis. I mean, I think obviously individual presenters could take out some of that if they felt like it. So the EMS role in sepsis is obviously just to give antibiotics and sort of try to recognize sepsis. And then this one I had just replaced these two slides with the sepsis TTTG. I think I need to change the order of that slide. I meant to put the whole TTTG up and then break it down. So, but basically I tried to cut it into pieces so it would look like less on the slide if you were teaching to these TTTGs. I just put each box sort of individually on the slide, and then below it is the shock TTTG as well. I don't know if we want to keep both of these in here. I think they're both relatively relevant to treating septic patients. I'm open to having one or both of them.
You want me to keep scrolling?
Yeah, sure. And then there's this slide about dopamine. And I wasn't sure if these respiratory things were a little bit out of place because it's sort of like at the end of the presentation, the respiratory component of sepsis. I don't know if this would be better up earlier in the presentation. I have left it here for now, but it just talks about ARDS.
I have a question about, sorry, it's Josh Gaither. When it comes to ARDS, is that something that we expect our pre-hospital providers to be aware of or diagnose or in any way change their patient management as a result of it? It's striking to me that you can't diagnose this in the field. You wouldn't change your management of any patient based on this. So other than a pure awareness, it holds very little value. So I would support removing it, I think, unless someone else has other feelings.
I agree. It's probably just a basic knowledge of some of these things that people might have a history of or diagnosed of.
So if you scroll up one, Shelley, what is the first of the? I mean, I think we can probably take out the ARDS reference, maybe? I don't know. And just talk about.
But I think you could just leave it as a bullet point at the bottom there.
Yeah. Or I'll call it acute respiratory distress syndrome because I think it should be acute, not adult.
Correct.
I'll change that as well. And then take out those slides that are titled ARDS.
Correct.
Okay.
This is Gail. What do you think about maybe at least putting the definition for ARDS in the kind of notes section?
Sure.
just so that way if someone is reading this and they don't know what it is, we at least have that note available for them.
Okay. Okay. And then moving on. And that was the end of it. Did anyone have any other things that they noted or saw or felt were either too much or not enough?
I don't see any
Cool.
comments in the chat area.
Okay, all right. So if there's no other discussion, we can take a motion to approve the changes to the sepsis PowerPoint.
So moved, Brian.
Sharon Hollingsworth seconds it.
Okay, all in favor of accepting the changes?
Aye.
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 And then any opposed? Okay. All right, so for the next action item, we have to discuss, amend, and approve the BRUI PowerPoint. So if I can get a motion to discuss this one as well.
This is Chris Long. I move to discuss.
It's Josh Cather, I'll second.
Great, thank you. So Dr. Woolridge had reviewed this and made a couple of recommendations to the BRUI PowerPoint, and then I saw a typo this morning that we probably should change when I was flipping through it again. But if we kind of scroll through, kind of goes through the definition, the on-scene evaluation for, and then talks about the history. So the first place that there was a recommended change was this addition of asking, was there a change in skin color? So Dr. Woolridge felt this was a pretty relevant question to ask, just to put in the history, because it could suggest, different things versus being cyanotic or, breath holding or everything. So this was a recommendation by Dr. Woolridge to put this question in there. Is there any discussion on that? Okay. If not, we can move on forward. This one.
Can you? I'm sorry, Dr. Price.
Yeah.
Maybe you can put any signs of cyanosis. I don't know.
Yes, you can say something like that.
Instead of, is there a change in color? that's kind of funny, actually.
Mm-hmm.
I think that's absolutely fine because it captures the intent. But our parents who report the event are very often not medically trained. So as long as we translate that in the field to what the parent may be able to identify. Later on in the PowerPoint, there's a discussion of peripheral versus central cyanosis, which again, as medical providers, we're aware of, but not necessarily the characteristics. So if you say cyanosis, I'd want to say, well, why and where was it in distinguishing? But I think our EMS providers have the wherewithal to translate that in the field. So your suggestion is nothing I would object to.
I agree.
Okay, so change the wording to, was there cyanosis? Okay, and then down in the history section, talking about, getting medical history from the parents. I think Dale, you had made a comment about asking about GERD or aspiration, and whether or not this could potentially lead a provider to like sort of deter transport because of something that was perceived to be maybe a not a big issue. Did you want to elaborate more on that?
Yeah, it was just it wasn't necessarily to adjust the slide per se, but more to express a cautionary point. The most common missed brewery event that later turns out to be negative outcome is essentially chalking it off to reflux. So children who have reflux can still have life-threatening events. So asking and or focusing on GERDs too much in the field may give a false sense of security. I think that was my only point that I wanted to make.
What about a sub-bullet that said something like the most commonly missed, a common cause for missing a bad, leading to a bad outcome is GERD or something like, I don't know, I'm trying to figure out how to word it. A sub-bullet that explained that caution.
Yeah, goodness. Has the event.
Or history of GERD should not deter transport for suspected brewery.
Yeah, but
I don't know.
I don't know. I would welcome comments from the group.
So this is Gail. I think later in the presentation, we really discuss, and in the treatment guideline, the importance that these patients all get transported, or if parents actually try to refuse transport, that there's online medical directions. So I think this is more kind of the background history to kind of explain to EMS that sometimes things like GERD or reflux or aspiration will be described by the family as a brew type presentation. So I would recommend leaving it in. I think later on we really talk about the importance of these children being transported.
Okay. Any other discussion on that point? Otherwise, we'll just kind of leave it as is for now. Moving on, just goes through specific things to look at on your physical exam. And then another recommendation from Dale to move from the 10-4 rule to the 10-4 faces for abnormal bruising. It was a little bit updated. I think it's from like a 2010 pediatric publication. It just basically adds on the 10 part, so torso, ears, and neck. And then the faces. Frenulum, angle of the jaw, cheek, eyelids, and subconjunctival hemorrhage.
And as Amber appropriately stated, this was a subsequent publication that further clarified concerning findings of inflicted injury patterns. And the FACES acronym does stand for certain regions of the body. So it gives a little more definition than just the 10-4. Most have considered it in the child abuse field to be a positive addition to the role.
Can you go up one, Shelley? Because the 4 also we clarified in this slide above here. Any bruising in an immobile infant less than 4 months. This is where the 4 comes in. And then in a child less than 4 years, any bruising in these areas. Okay, so we can move on. I just wanted to clarify that. Epidemiology. And then this is the slide I saw, I thought we should probably change Alti to Brewy on that slide, and I just caught that. So we can change that. Here's the slide that goes into a little bit more about GERD. And then I put in the updated Brewy TTTG. This slide goes into about the importance of ED evaluation, It talks about all the things that they may potentially do in the hospital on a child with one of these unexplained events. Slide about what the final diagnosis ends up being. And a little bit about prognosis. And then there's several cases here for discussion that there were no recommended changes to.
I'll just scroll to the bottom.
Okay. So in the cases, there's a little more explanation of some of these other things. Then they had the TTTG in there again after the cases for review. And then like Gail said, at the end, it sort of summarizes that these are high-risk patients and should be encouraged to be seen in the hospital.
Dr. Rice, Orlando. I have a comment. So on that facial bruising, I'm assuming that all the educators are careful on making sure that, you know, that could mimic abuse, right? So everybody's somewhat correlating that, making sure that there is a difference between those type of presentation.
You mean the bruising that suggests abuse that we have in there?
Yeah, I was just kind of stuck on those pictures, and I just wanted to make sure that, you know, whoever's teaching that is, you know, these are, is there a difference between abuse types of facial features and so on and so forth?
So should we clarify?
I mean,
so clarify further in there that those are patterns of abuse that we're describing there? Make it more clear that those are patterns of abuse in the slide? Is that what you're asking?
Orlando, you're muted yourself.
yeah, on the slide that says abnormal bruising, I just wanted to make a comment that, you know, everyone understands that these are.
Okay. Trying to remember what it says.
Yeah, it's the facial bruising slide.
Okay.
That one, yeah.
Okay.
These are,
So put like underneath maybe like patterns of abuse.
This is Gail. So I think what Orlando's referring to, the original picture, the older version in that kind of handout that we have a strike through, I think in there it specifically said that this bruising is abnormal and needs to be reported to CPS. So I think just based on the CPS language, it's dated, but I think that's, I think was maybe we just need to add somewhere a notation that when we say abnormal bruising, i.e. indicative of abuse, something somewhere on the slide just to kind of make that clear.
Maybe on this slide right here, this one right here, any bruising in an infant, and then put underneath like a third bullet that says, you know, abnormal suspicious for abuse should be reported to.
Or maybe a comment that just says, you know, findings that are consistent with inflicted injury. I like the term inflicted injury more than I do abuse, because inflicted injury can still be accidental in nature. They just need to be scrutinized.
Okay.
Yeah. Okay. Sorry, I got stuck on the picture, so I just was reading it, making sure.
It should be.
Yeah. You know, and I forgive me if I'm speaking too much, but in your next slide, it does outline on the right side of the right panel, FACES, and FACES being an acronym for standing for those bulleted items.
Mm-hmm.
I mean, could they be? I mean, is that apparent to the individual reader, or should they be, hyphenated between them so everybody knows that it's not? We're not talking about the actual face itself. We're talking about the acronym faces. Is that the distractor? I think. Am I reading, Orlando? Am I kind of reading into what you were saying earlier?
Yeah, and yeah, that makes sense. I mean, just the acronym itself.
We'll clarify that that's the acronym.
Could we just outline the capital letters in a different color, maybe make them red so that you see its faces more?
Sure.
Yeah, I like that.
There you go. There you go.
Or just put periods in between them all, the letters.
Okay. Do we still want to make a statement in there about findings consistent with inflicted injury should be appropriately reported?
Is that in the treatment guideline with that reference and with any CPS numbers or anything?
I don't know if there's numbers. You might have to lay that up. The guideline.
I don't think it is.
Okay. I thought at one time we had that information in there. So at least it would be directed there.
I think it is in the suspected abuse, and I think in the entire version of the TTTG, I believe we had the 10-4 picture on there, but we may not. But I do think that Orlando's point was a gone good one. Of just making sure that we kind of indicate that this is abnormal bruising indicative of potential, I like the term from Dale, inflicted injury.
Yeah. Yeah, so we can just call that slide. We can just say abnormal bruising consistent with inflicted injury. And that would be on there to be clear that we're talking about potential child abuse. And did we want to put in the TTTG for suspected abuse? I didn't think of that before, but we could put that at the end as well.
Yeah, I'm good with that. I think just a reference, just making sure that whoever's teaching this need to explain it a little bit more clearly on this kind of situation.
Okay. All right. Thank you, everybody, for all your comments. Anyone have anything else to discuss in here? If not, we can take a motion to approve the changes.
So moved, Brian.
Thank you, Brian.
Second, Orlando.
Okay, all in favor? Say aye.
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 Then any opposed, say nay. Okay, we should have time to move on to our next action item. Discussing and amending the changes to the chest compression only CPR. So if I can get a motion to discuss this one as well.
So moved, Matt.
I can second.
Great. So this PowerPoint presentation is from 2009-ish. It was put together by the Sarver group to teach chest compression only CPR and has been up on the Bureau website to mostly for lay rescuers as part of the naloxone education. So this isn't really a EMS provider education. So keeping that in mind, we can kind of scroll through some of these. The first slide talks about sudden cardiac arrest and kind of gives some different examples of younger people that have had cardiac arrests. This one, I had recommended striking the first one out just because it's quite outdated, and I brought in a new chart from the updated CDC statistics for causes of death in the US, and just tried to make the words bigger for heart disease so it was easier to read. On the next slide, I kind of took some of those stats from above and added them to this slide, talking about sudden cardiac arrest specifically. So before it had been on a slide with heart disease, which I thought was a little bit confusing. So kind of breaking out sudden cardiac arrest statistics into its own slide, talking about how many people have a cardiac arrest each year. So this 350,000 is one of the most up-to-date statistics. I think it's like 356,000-ish most recently, and then put some specific statistics in it that might be relevant to somebody who would be responding. So 70% of these occur in a home or residence. Nearly 90% will not survive. Out-of-hospital cardiac arrest in adults is witnessed by a layperson in 37% of the cases. And then this last bullet, I put in here for discussion also. I don't know how useful it is to lay rescuers, just because there's a lot of stats in that bullet. So we may want to just strike it, but just talking about the survival variation in out-of-hospital cardiac arrest does have to do with rates of bystander CPR and lay rescuer AED use. So just highlighting the importance of bystander CPR. This slide, I wasn't sure how helpful it was, this fact versus fiction cardiac arrest slide. This one I left in just, I think the lay rescuer does not always understand the difference between a heart attack and cardiac arrest, so I left that one in there. My recommendation was to remove this primary versus secondary cardiac arrest. I don't think it's something I would expect to be able to teach a lay rescuer or law enforcement officer who, is many of the people that were teaching this to understand the difference between a primary and a secondary cardiac arrest, nor would it change what they would do. So my suggestion was to remove this. This one as well, just because I don't think that I have a reference to it in a second, that most of these are primary cardiac arrests. And then change the verbiage on the what is compression only CPR to be just a little bit updated. So talking about compressions only without rescue breathing, added in that it's for non-healthcare providers or healthcare providers off duty without special equipment. And then this is the part I took from above, saying in many cases of out-of-hospital cardiac arrest, immediate oxygen is not helpful and could be harmful. Instead of providing further explanation than that, I didn't know that it would be information that would be retained by a lay rescuer. Down here, I took out the word primary and just put most, since that's what the slides above referred to, the fact that most of the time these cardiac arrests are primarily cardiac in nature. So I just put rescue breathing not necessary because during most cardiac arrests, we have oxygen and the blood is full of oxygen. Going down, this right here, talking about increased intrathoracic pressure, I thought was something that wouldn't be easily understood by a lay rescuer, so I recommended taking that out. This, I think, is useful to explain that when we pause doing chest compressions, we aren't providing blood flow to the brain. So I think that this slide is useful, even though it is somewhat sort of sciencey, but gives you a visual. Why chest compression only CPR? I recommended changing the verbiage of this last bullet to be just a little bit more specific about that it takes a few minutes for trained responders to get there, and we'd already be getting brain damage, and taking out the interruption of chest compressions part. What stops people from doing CPR? These are statistics from one of Dr. Bob Rao's papers showing bystander CPR in Arizona. So looking at the first slide is all out-of-hospital cardiac arrests and survival of hospital discharge with no traditional and chest compression only CPR. And then the second slide is the witnessed primary cardiac arrest. So these are our VFib arrests on the next slide, Shelley. So I don't know if we want to keep these graphs in there. I think they're maybe somewhat difficult for a lay responder to understand, but does provide you a visual that chest compression CPR is a good thing to do.
I think this is Matt. I think it'd probably be worth getting rid of the word primary in that slide right there, since we've gotten rid of it everywhere else. If we're going to keep that slide, I think it's worthwhile, but I would get rid of primary.
Okay. Okay.
This is Gail. One thing, just as you're scrolling, I noticed the red font, when in doubt, decompressions with the shadowing underneath. I'll just make a note that we might want to get rid of that shadowing underneath the red font. It's a little thing, but it's a little distracting. I think it's on just a couple slides.
Yeah, I'm happy to do it. I noticed it too, but I was trying not to be nitpicky.
This is Sandy on the data.
That was for Alice. That was for Allison. She was sitting here going, "I don't like that red font."
So ugly. Yes, Sandy.
On the data on the slides that you have with the graphs, is it possible? Do we have any updated data by any chance? Because that data is 10 years old.
There have been a couple other studies. The most recent one was a European study, not one out of Arizona. I don't know.
Okay, I kind of think 10-year-old data is a little bit kind of confusing. I'm sure we've done better since then.
Yeah.
So to address that concern, you could just remove the date from the title and put it in a footnote. You're never going to get this data again. So this is probably not something that will ever be repeated. So asking for more up-to-date data, I don't know that that's going to be a realistic request.
Yeah, I like your idea of taking the dates out. That's a good suggestion.
Okay. Okay, can do that. So these slides I added because there wasn't any reference to the way we have moved to identify out-of-hospital cardiac arrest in recent years, which is basically, are they conscious and breathing normally? There wasn't any reference to that in this slide deck. So I thought the first step really is just outline the fact that the first thing we're going to do is check and see if the patient is conscious and breathing normally, and then go into a little bit more about that. So what I added was this: check, shake and shout, are they breathing normally? And then call 911, and then compress, and I updated the numbers to reflect the updated American Heart Association and literature that suggests that there is an upper limit to chest compressions. Even though it is for lay respiratory, I still think it's important to go through it.
Hi, it's Brian.
Yeah, Brian.
I have a question, actually, back up on a little bit earlier slide where it talks about traditional CPR.
Mm-hmm.
Right there.
Mm-hmm.
So I recently became a coordinator for a PAD program, and I'm teaching chest compression only CPR.
Mm-hmm.
And so there's nothing about traditional CPR, what might happen. To me, it seems if we're doing chest compression only CPR, that to throw in the traditional CPR when you're not teaching that version of it may be confusing to the issue. So
yeah, I do agree with you. I'd be in favor of taking this out. If someone were trained in traditional CPR, though, like if you had folks in the crowd that you were teaching, and some of them were trained in traditional CPR, I think in some of these situations, you know, the preference would be for them to do traditional CPR.
Could we then add in if trained or something like that?
Yeah, and so I think like you have to be trained and have appropriate equipment.
So this is Gail. I think this went back probably 5 or 6 years ago when we first rolled out the naloxone instruction to law enforcement, and we had extensive debate at that time in terms of what type of chest compressions to teach. Having kind of done that with a pretty large volume with ADHS of law enforcement across the state of Arizona, I was actually surprised that there were some agencies that had BVMs, and so for them, they would be able to potentially bag a patient, and we're trained in doing that. So for an overdose, and really the reason we have this PowerPoint up is to go along with the naloxone training.
Yeah.
So we did go back and forth because we really felt, and what I told people, if you don't have the right PPE or you don't have the equipment, just do chest compressions only, even if you see a heroin syringe next to them, because you want to at least do something. So if it's something or nothing, do the chest compressions only. Certainly, if you have the training and have PPE, I think with an overdose, you would preferentially, just like choking or drowning, want to do traditional CPR.
Yeah.
So maybe I think adding the language about if trained and have appropriate equipment / PPE.
Okay.
Maybe we should just make that a separate slide. That particular point underneath. If you are trained in traditional CPR and have the equipment.
So break this up into 2 slides.
Maybe that might be a little less confusing.
Okay, so chest compression only CPR, and then the vast majority, and then on the next slide, traditional CPR if trained, and then make a separate slide. Does anyone else have any comment about that? Go ahead.
Am I tracking? Where are we?
I don't know. Go up a little bit.
Okay, sorry.
One more. Yeah, that one. Does anyone else have any thoughts about 1 versus 2 slides for this? If we put it on 2 slides, whoever's doing the training could potentially take out the slide about traditional CPR if it did not apply, if we break it up into 2 slides.
Is this read only on the website? I don't remember when I downloaded this if I was able to change it or not.
It was read only on the website, but I did get the PowerPoint from Shelley, so once we make the changes, we can put it up in PowerPoint format.
Okay.
So 2 slides, is that our sort of consensus?
I think that would be good.
Okay. And then I'll put the when in doubt, do compressions at the bottom of the traditional CPR slide so that it's clear. Okay. And then on the next slide, this was a new slide that I added. Oh yeah, we already did this. First step, keep going, keep going. So this is verbiage that was added. Are they breathing normally? Just that we're consistent with how we identify cardiac arrest. So the next slide, are they conscious? I've just sort of broken these up into separate steps. Are they conscious? Yell to victim, tap or shake to try to get a response. If they are not conscious or semi-conscious, move on to check for normal breathing. Normal breathing, I put breathing normally means appearing to breathe normally or talk. If the victim can be short of breath, but if they are still talking, they don't immediately need chest compressions. Agonal, really slow, or gasping is the same as no breathing. So if the victim is conscious and not breathing normally or is gasping, immediately begin chest compressions. I don't know if this is too wordy, too much. If anyone has suggestions, happy to change any of that around.
I think these are really good updates.
Dr. Rice, I think we should also add that, the dispatch center, when they call 911, that obviously this is for layperson, if that's our target audience is, that dispatch center can coach them through this process. So I don't know if that will help a layperson that's taking this or whoever's presenting that, obviously that's another resource where they can leave the cell phone on and that they can be coached through that process. So I don't know if that can be put in there somewhere when they call 911.
Yeah, like up higher, you mean? Let's scroll up and see where we would put that. Oh.
Yeah, somewhere in that call 911. Obviously, yeah, because I've actually taught this in high school and with teachers, and I told them that they're there for you and that they can certainly coach you through the process. Instead of just having, oh my gosh, okay, just need to do compressions and, so definitely probably need to advocate that so that they know that they have a resource.
Yeah, I think the only exception would be places that don't have emergency medical dispatchers do their dispatching. I don't know how good the pre-arrival instructions would be, but probably for the vast majority of people. I can put that right under send someone for an AED, and then the second line can be 911 dispatchers can coach you through CPR or something like that.
Could we put may?
Yeah.
I know, and maybe it's all been resolved, but I know several years ago that even up in the northern region, I think Dr. Bob Rowe and some others were traveling around to the dispatch centers to try to get them to take on the effort of providing for compression-only CPR before EMS arrival. And I don't know if maybe everywhere it's done, and maybe there isn't, because DHS, I think, ultimately kind of didn't have that much authority over dispatch centers.
Yeah, I know that we have in our region dispatch centers that don't provide adequate pre-arrival instructions because they don't do, it's out of the sheriff's department or whatever. So yeah, I can put may be able to coach you. Okay, good idea. And then going back down now. Oh, up a little bit, Shelley, sorry. Up a little bit more. One more. Oh, sorry, down. That's my fault. Okay, so this one talks about are they breathing normally, and then down below, I kept some of the stuff in that they had about gasping. Don't know if this is necessary second slide about it, but I left this in. Talking specifically about how they might be gasping, but don't stop your chest compressions. I think it's useful information. How to do chest compressions, I just kind of simplified this slide and put the hand position, body position, and broke it up into 2 slides. So it was kind of all on one slide with the next one. And I just broke it up and made the pictures kind of bigger. One suggestion was to kind of talk about taking your weight off the chest a little bit more. If all we're teaching is chest compressions, then doing good chest compressions would be obviously important. So there's a recommendation to put in there, take all your weight off the chest to make sure that we're describing that when we're teaching this class. And then the next slide, I just updated the rate and depth. So I took this slide out and then changed it. can go further and just put in here that this is the optimal chest compression, but hard to achieve without special equipment, just so that people understand that obviously you're not sure without the right equipment how deep or fast you're going, but to err on the side of too deep and take all your weight off the chest with each compression. So just based on what we know. And then things to remember: push deep and come up all the way, keep a beat. So talking about an app for a metronome. Don't worry about hurting the patient. So this is stuff I just kind of put together from some of the other slides and put it on things to remember. And then here, the next one is just a couple things about an AED if you're teaching that. I don't think I changed any of that. And that was it. And then the rest of these were their like appendix slides. I just left in place. So that was it. Does anyone else have any comments or thoughts? Thank you guys for all of your suggestions.
That was awesome. That was really a ton of work that you guys put in, and I appreciate all the effort to get these updated.
Yeah, thank you everyone for all your input, for sure. If there are no more discussions for this one, maybe we can get an amendment to approve this one.
So moved, Brian.
Thank you, Brian.
Second, Orlando.
Thank you guys. And I will make the edits on these. Oh, sorry. All in favor, say aye.
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 And then any opposed, say nay. Super duper. I will make the edits, and I'll have Shelly send out to the group in case you want to comb through it, make sure I didn't make any mistakes, and then we can put it up on the website. The next action item is to discuss the bylaws review and roster roles. This is the last thing I have on my action items. So if we have a motion to discuss this, I have just a couple things to say about it.
Still moved. This is Matt.
Thank you, Matt.
Second, Brian.
Okay, so the bylaws are up for review by the end of the year. I'm going to let Gail say a little bit more about this. So if you guys want to take a look at it, the one thing that I have on here to discuss is the roster and the roster roles and sort of like where these different roles are assigned from. So do you want to talk a little bit more about that?
Sure. Thank you, Amber. So one of the things that we are trying to do, just to give a little background for those of you who weren't on the previous meeting, the statutory committees their rosters are defined in statute. For the standing committee, we have a little bit more flexibility in that the committee can actually approve the bylaws and the roster. What we've been trying to do and struggling over the last couple of years is to get even representation from definitely the 4 regions, but then also the different kind of stakeholders in the EMS community. And so we've done some work kind of reorienting some of this to make sure that we have appropriate representation with the goal for us to have 2 representatives from each region that are elected. So that way, if someone does move, step down from the position or resign, then it's very clear who we are going to, which region we go to have someone replace them. So that's kind of the main goal of what we're trying to do. We do have a liaison from each of these statutory councils. So there's a liaison from EMS Council, MDC, and STAB. And one of the ones we'd like to put forward to the region to consider, or to this group, would be to have a PACES representative. Since PACES is now a part of the Bureau of EMS and Trauma System, we thought that it would be good to have a PACES rep as a formal member of this education committee, especially as a lot of the education we do is focused on pediatrics. And then also would like to consider, as we restructure this, having one of the representatives be a representative from the National Association of EMS Physicians Arizona chapter. So that was kind of the recommendations we wanted to bring forward to this group to discuss and consider. And this is not a formal vote today, so today's really a discussion piece. At the next meeting in November, at that point, we would need to make a formal vote, and it will be an action item. We just wanted to have this as a discussion item to start the conversation.
Yeah, so we discussed a sort of similarly for the TEPI meeting. It was pretty widely accepted as that people were in favor of making these types of changes. Are there any thoughts about from this committee for or against making these changes and just clearing up a little bit the evenness of the roster? I'm not hearing anybody.
I don't see any chat entries regarding this.
Okay.
Yeah, that's good. Let's add that, Orlando.
Perfect. Thank you, Orlando. Okay, so we have a little bit of a general consensus that this would be an acceptable potential change to bring forward when we further discuss the bylaws changes. Were there any other recommendations, Dr. Bradley, about the bylaws in general? This was the only thing that stood out to me as recommended change.
That was really the only one, unless anyone in this group, we wanted to make sure that we kind of got it in front of the committee. I know bylaws is not the most fun thing to review, but rather than having an entire additional meeting to just go over bylaws, if the group wants, we could certainly bring a work group together to do that. But just to kind of, at least start reviewing this, and then at the next meeting in November, we could vote on any proposed changes. So more of an awareness. We wanted to make sure that we could kind of work on the roster in the interim. And if the group's comfortable with the direction of the roster, we would bring that forward for a formal vote in November. And then also, if the group can just take some time between now and November to look over the bylaws and see if there's anything they would like changed.
Mm-hmm. Does anyone feel that we need a separate work group for this, or is this something that you guys would be okay with putting on the agenda to discuss at the next meeting? Not a terribly long document, so I think we definitely would have time to discuss it as a full group, which would sort of be my recommendation, just to put it on the agenda for November.
I think that's fine.
Okay. Okay, well, there's nothing to vote on for this one. So if there's no further discussion about the bylaws, we can discuss any additional agenda items that would need to be on November's agenda. So does anybody have anything that they feel needs to be put forth on the November agenda? Just a second to think about it. Okay, if not, next on the agenda for today is the call to the public. If anyone has anything? Okay, hearing none. Upcoming events, there's a pediatric care after resuscitation course. This is an online course, November 17th and 18th. And then a plug for the Bureau's website, the news and conference page for other upcoming events, and the training page for upcoming CE opportunities. Our next meeting will be November 19th. And who knows where it will be, but maybe online, maybe in person, who knows. And with that, I have nothing else. If I can have a motion to adjourn the meeting.
So moved, Brian.
Thank you, Brian.
Second, Orlando.
Great. Okay, all right, and with that, we'll adjourn.
Thank you, everyone.
Thank you.
Stay safe. Bye.
Bye.